Right, good evening, everyone. Welcome to our healthier community and older people's overview and scrutiny panel. My name is Councillor Agatha Gina. I'm the chair of this panel. I think everybody on the panel should introduce themselves. Would you like to introduce yourself?
Councillor Jennifer Gould.
Councillor Caroline Charles.
Councillor Lakshmi Attawa from Collierswood.
Councillor Sławek-Szywański, Lavender Hill.
Councillor Tony Rice.
Councillor Eleanor Cox.
Rosie McKeever, Scrutiny Officer.
Thank you very much. Right, before I start, I've got an announcement I'd like to make. Generally, this is for the public or the members of the committees or the members who come to the committee to present whatever topic we've asked for. It happens to be NHS today, so don't take it personal. So what I'm going to announce is that NHS colleagues are reminded that under the Health and Care Act 2022, health scrutiny committees such as this one has the power to make reports and recommendations to NHS bodies and receive a response within 28 days. So if we do make recommendations, we would like a response within 28 days. So I just thought I'll put that out there. So thank you for that. We're going to be actually swapping the presentations around because James, Chief Executive,
Managing Director.
Managing Director from St Heliers is on call. So I'm afraid he's got to leave us. So he's going to be number one. So if we can get an update from him, and then we've got quite a few questions. So we would be grateful if we could get an update so we can ask you what we need to ask you. Thanks.
Thank you very much, Chairman. So my name is James Blyth. I'm Managing Director of Epsom and St Heliers University Hospitals NHS Trust, and I'm here with my colleague Andrew Asbury, who is our Group Chief Infrastructure Officer. We were asked by the chairman to come tonight to talk specifically about some of the estate's challenges at St Heliers Hospital and how we continue to tackle these on a day-to-day and year-to-year basis alongside the development of our Building Your Future hospital scheme, about which I know that the committee is well versed. I will do a little bit to set the context and some of the operational challenges that we see around the St Heliers site, and then Andrew will take the committee through a little bit of detail in terms of some of the things that we have been doing and indeed plan to do this year as we continue to invest in and develop the site, both in terms of maintaining the safety and effectiveness of current services, but also with a view to its future use as a district hospital site, retaining 85% of the current service provision under the future configuration. So if I just move through the slides in the pack, the first slide is titled About St Heliers Hospital, and it just gives a little bit of context to the hospital. I know this will be familiar ground to colleagues here. So the hospital is from the late 30s and early 40s, and there is a significant problem with the state of the estate. Which a large part of that relates to the basic fabric of the building. So either the actual concrete and the fabric that it's made out of, or some of the core services that are integral to the site. It also relates to the spacing and the footprint of the site. So obviously we have a building that was configured around 1930s and 1940s healthcare standards, and those standards are significantly different, and that influences things such as the spacing of the beds, the design and the configuration of the wards. It also influences the ability to install modern services such as ventilation into the original fabric of the building. So things which couldn't have been anticipated in the 30s and 40s are now more difficult to do when you're looking to upgrade a building to modern healthcare standards. Moving on to the next slide, which is entitled Challenges with Our Old Estate. We explore this in a little bit more detail, and about how those challenges have practically impacted on us. At the same time, we also have listed on this slide some of the work that historically has taken place in order to continue to develop and improve services on the site, including the development of same-day emergency care, which is a more modern way of treating patients who present at A&E, and some of the working on, for example, B and C blocks, and also some of the basic services provided to the site. And Andrew will go through some of the schemes in more detail in a moment. The practical consequence of this for us is that it has the fact that we are in an old building, the fact we're in a building that is very difficult to get to modern standards in terms of space, in terms of services provided from within that building, is that there is an impact on patient safety and experience, and also on our staff experience as well. And we've recently had hot weather, and as ever with hot weather, that is a challenge in a concrete building that never had mechanical ventilation installed. So maintaining the temperature at one that's an appropriate therapeutic environment, it's also an appropriate working environment for staff doing difficult jobs, is a constant challenge, and it's one that we are continually seeking to mitigate, but there is a limit to how far we can push those mitigations. Our estates team works very hard to sort of stretch them and to make the environment as amenable as possible, but there is a limit. I think it is testament to the work of the estates team and of our clinical teams that we have a CQC good rating in the context of those very significant challenges. The case for change that we've made, and I'll come on to talk about it a little bit later, however, is not just about developing the estate at St Helier, or indeed the estate at Epsom, where there are similar but slightly less acute challenges. It is also about the fact that we have two sites providing 24/7 services on a subscale basis. And actually what we know is that we can deliver more sustainability in terms of our workforce, and we can deliver higher quality, as well as address some of our estate's challenges by bringing those two sets of 24/7 services. And some of the rationale for that is laid out on that slide. At this point, I will revert to the subject of the new hospital and our planned development at the end of the presentation, but I'd like to hand over to Andrew to talk about some of the more sort of technical aspects and some of the detail of what we're doing with the estate at the moment.
Thank you, James. Good evening, everybody. My name is Andrew Asbury. I'm the Group Infrastructure Officer for George's and Epsom St Helier. I've had this post for about 5 months, so I'm relatively new in role. Previously, I was the Director of Estates at George's. I'll just talk you through initially at a strategic level, I guess, some of the things that we are doing. So we're just about to launch a new, what we call in the NHS, a 6-facet condition survey that will give us a more up-to-date picture of the condition and functionality issues that we have across the estate, together with what some of the solutions would be to resolve them. We're developing a group sustainability strategy to help us achieve the NHS's net zero strategy, and a group estate strategy as well that will bring together our plans for the estate for the next 5 or 10 years. The next 3 slides, I think, just highlight the level of investment that does go into St Helier. So since 2020, I think there's approximately around £30 million that has been spent specifically on addressing some of the estate's challenges. They range from quite technical estates issues through refurbishments for patient-facing areas, together with things that happen behind the scenes with air handling units and chillers and things like that to meet the technical requirements for patient safety we need to address. And we continue to do that. So this year we're planning on spending another £7 to £8 million this year purely on estates issues at St Helier, with a range of projects that you can see, from window replacements to, again, more air handling units. We, a couple of weeks ago, did a major project to replace and upgrade the incoming cold water systems there. So that has already been completed in year. So we do invest significant sums into maintaining St Helier, and we continue to do so.
Thank you, Andrew. So I'd just like to move on to the penultimate slide, which is entitled Building Your Future Hospitals Programme Update. So I think I've previously updated the committee at some length around the Building Your Future Hospitals programme. So this is the reconfiguration of Epsom and St Helier to consolidate 6 major acute services onto a new specialist emergency care hospital based at Sutton, and that this is part of the government's new hospitals programme. And I've talked previously about some of the benefits of being part of a national infrastructure programme, which is what we now are, but equally some of the challenges that we've had in the recent past in terms of certainty about how and when the programme will proceed. I would say that I think those challenges are beginning to resolve. So we had an announcement from Secretary of State on the 25th of May, and that announcement committed that our scheme, as part of the National New Hospitals Programme, would proceed and would be fully funded and would be delivered by 2030 using what's being called a Hospital 2.0 approach. So this is the government's sort of standardised approach to designing and procuring new hospital schemes across the NHS. I think I previously said that I think we would all, as taxpayers, expect that if government is going to build a significant element of infrastructure which has some replicable elements, we would expect them to seek best value for money and consistency in how they do that, and that's what they're doing. So we know that the next period for us very much looks like quite intensive work with the National New Hospitals Programme to take their blueprint for new hospitals across the NHS and work out how that applies specifically to our context, which is building the specialist emergency care at hospital at Sutton. In the meantime, we're looking to proceed with enabling works as much as possible, and indeed we've already started to clear the site so that we have a clear site and are ready to begin working on it as soon as we can. As you can imagine, we will need to work really closely with the national programme. We're working very closely with our integrated care boards in South West London and Surrey to confirm the assumptions that were made in the original case and to continue to develop them so that the scheme can, this part of the National New Hospitals Programme scheme can seek approval. But what Secretary of State has said is he expects that to be an accelerated process because a number of schemes are going to be going through the same checks and approvals together. So we don't know a huge amount more than that at this stage. As I say, we're in, and I know that the team was just meeting with the New Hospitals Programme today to work through some of the detail around that. But we would, of course, be very happy to continue to update the committee as we know more about the precise timescales and phasing, and when progress will continue to become more visible about the delivery of our new hospital. Thank you, Councillor. That's I think all we wanted to say at this stage.
Thank you very much. We have questions. I think some you may have answered, but we're going to go through all the questions anyway. All right, we'll start with.
Thank you, Chair. Thank you, James. I've got a question on a request. Why have you not provided the information and the documentation requested? And can this be sent to the scrutiny now?
I'm sorry, I didn't quite hear the full question.
I did ask about the documentation requested in a letter. Why that hasn't been sent to us, and can you send it now?
And what documentation would it be
with the-
specifically helpful to see?
The letter was sent from Agatha below, and the request was the impact on the disrepair, the impact on hospital staff, previous and planned capital investment, deterioration of the and extent of deterioration, plans in place to urgently address those issues, and they need to consider rephasing the capital investment. Those were requested a while ago.
So we believe that the presentation we've supplied appropriately addresses those questions in terms of supplying information about the challenges that we have in terms of the estate at the moment, the impact on staff, and also the investments that we've made over the last 3 years and our planned investment for this year, with specific figures enclosed. So I think our view would be that we have supplied the information in the presentation, Councillor.
We don't feel that you supplied the information, but there's a lot of questions. We'll get back to that one. Okay.
Thank you, Chair, and thank you, James. Has the outline business case been agreed? And if not, what are the plans for submission, and how will Merton residents be involved in this?
So the outline business case has not proceeded to approval, and that's because we, in the development of the outline business case, we identified the need to work with the National New Hospitals Programme. So we are still confirming with the National New Hospitals Programme the process that we will go through in terms of outline business case approval. What I would say is that the focus of the outline business case is on the building itself, and the building in particular of the specialist emergency care hospital in Sutton. It will also cover some of the planned improvements that we're planning to make to both St Helier and Epsom hospital sites, but it is very much focused on the capital of the building. The consultation in terms of the configuration of services completed in July 2020, and we wouldn't expect to be revisiting the issues from that consultation in the OBC process.
Do you acknowledge that the only agreement to funding so far is some enabling works? Can you clarify what this entails? Will this blight the site if a future decision is made to develop the site differently?
So the commitment we have, so we had a commitment from government in 2020, and Secretary of State has reaffirmed that commitment very recently, and that is that our development will be fully funded to complete by 2030, and we have also completed the necessary consultation processes in terms of the service configuration. So as far as we are concerned, we are at the point now where what remains is to work through the detail with the National New Hospitals Programme. Now, that detail, I think, is in a number of areas. The first is to confirm that we can proceed with some of the enabling works, which we knew we always would need to undertake as part of any programme. There would be enabling works that sort of prepare the site, make sure that you're ready to proceed, and also there's the funding for us to proceed with the planning process as well. But then there is the discussion with the New Hospitals Programme in terms of the overall phasing of the development, so the timing, where we fit within the overall programme, so how our timing works with other schemes, because clearly one of the issues for the national programme is the capacity of the construction market to deliver multiple schemes at the same time. And then finally, how that sort of fits in terms of an overall envelope for the programme. So, we have the headline commitment and we are in the detailed discussions, and it is simply the phase of the detailed discussions that we're at, which is quite early following Secretary of State's announcement, that means that we're not in a position to provide any more detail at the moment.
Thank you. I'd like to take the opportunity to thank the staff, doctors and nurses for amazing work at St Helier Hospital in what can only be described as difficult circumstances regards to the building's disrepair. How much longer can St Helier remain a viable hospital without immediate repairs if, as planned, 85% of services are to remain on site, while over 80% of the estate, as stated in your slides, page 76, is not functionally suitable for delivery of modern patient care?
I mean,
Thank you. So my question was, I just had a quick look at CQC and I saw that the only area that was, you had a good overall rating, the only area that was requires improvement was about safety. So I'd love just to hear how sort of the new services you think will actually help improve that aspect of care as well.
so, oh, sorry.
So, oh, sorry. In terms of the building repair, how does that impact on the service that our other people are getting? Does it have to specifically impact on them, or will they still be able to get the care that they need, or will they have to go to another hospital to get that care? If it though, says Ella might be the closest hospital to them, how does that work?
So if I deal with the two questions about the future configuration first, and then perhaps revert to the one around the current state. So in terms of improving safety, I think it's a really good question. So what we know is that the challenge we have at the moment is with two relatively small major acute sites providing 24/7 services, but actually sustaining the staffing, sustaining the sort of new models of care that keep pace with changes in healthcare is very difficult to do on two small sort of 300 to 350 bedded sites. What the new configuration allows us to do is to bring together those 24/7 services. It allows us to innovate in terms of the workforce models that we have. It allows us to make sure that we've got more layers of 24/7 cover as well. So, you know, we can have more layers of seniority. We've got more scope to train people. We've got more scope to bring in different types of new workforce models as well. So recently, the NHS has started to use more advanced practitioners, more physicians associates as well. And there's more scope to use that wider workforce where we've got those 24/7 services consolidated. And I think the evidence from consolidation of major acute services. So, you know, bear in mind, this is a relatively small percentage of presentations overall at hospital. For example, with heart attack, for example, with stroke, with major trauma as well, is really compelling in terms of some of the quality benefits they bring. And we would certainly expect to see some similar quality benefits within the consolidation of major acute services. Just turning to the question about older people, I think that what's important within this is to consider that what we're planning is to retain that 85% of patient contacts at the St Helier site. So for older people, you know, typically their pattern of access would be that they will have a significant number of outpatient services. Now, some of those outpatient services are changing anyway. We are in general aiming to try and provide more support to GPs so that we don't have to keep bringing people back into hospital for individual appointments all of the time. But actually, when people do need to come for appointments, those would remain at St Helier. So outpatient appointments will remain at St Helier. We will also keep urgent treatment centres at St Helier and at Epsom, and indeed at the Specialist Emergency Care Hospital. And we will also have what we call the district hospital beds. So these are the below acute hospital level beds that will support people with rehabilitation. The only part that will be consolidated is if somebody is acutely unwell and needs the services of a specialist emergency care hospital, or they need surgery for which they stay overnight, which is a diminishing number of patients. And in those circumstances, those patients will go to the new site at Sutton. But obviously, if you need an emergency admission to hospital, in all likelihood, you are going in an ambulance. And our aim then is that you will be repatriated back to the St Helier site within 2 to 5 days. So that is the basis of the model. So what we're seeking to do is keep as many services as possible, as local as possible at St Helier, but where we have that need to do things once, because it's a major acute 24/7 service, those are the services that we're bringing together. So you get the bonus of the better quality from the bits that we will bring together, whilst keeping that local access wherever we can. Just on the point about how we sort of bridge the gap between where we are at the moment and where we want to be. I think what we are looking to do is invest in the parts of the estate in particular that we are planning to hold on to in the future, and invest in them in such a way that it makes them fit for what we want them to do in the future. So we're not planning to hold on to all of clinical services in all of the site. We will consolidate down to a smaller footprint, and it is those parts of the footprint that we are intending that we can make good for the what we need them to do in the future. So I didn't know whether, Andrew, you wanted to talk a little bit about the kind of overall how we sort of plan around that.
Yes, I mean, thank you, James. Just to pick up on one of the points about how do we do some of the works today, whilst we maintain the patient experience and making sure that we don't affect safety. It is an awful amount of planning and a lot of coordination with our clinical teams. So, for example, the major water replacement that happened a couple of weeks ago, all of that was completed overnight. So we didn't start works until 11 p.m. They ran through until 4 a.m. Clinical teams have been involved in all of the planning for that. We had contingency plans in case we had to do disaster recovery. So it's about working very closely with our clinical teams to get the access that we need. And I think to pick up the point, as James was just starting about how do we retain the 85% patients with the 80%. So we are doing that right now by the investments that we're already undertaking, and it is about dovetailing the work that we are doing on the existing estate, knowing what the future plans are. And obviously, as the programme begins to develop and the emergency care hospital becomes available, that will then begin to free up some capacity on the site, which we don't have at the moment. So that will enable us then to much more quickly be able to create plans around phasing and decanting, so that we can do a much more significant level of work at towards the 2030 at the tail end of the programme, to get those improvements in place for the 85% of patients that will still be using the hospital.
Yeah, I know. I'd like to ask you a question. I think you've touched on it, but I'd like you to come back on it. What was the cost identified in the 6 facet survey in 2019 of the investment required to make good deficiencies in the estate? And the follow-up was, is it likely that this is far less than the 500 million cost of a new hospital project, and that they will not want to reveal? But this cost, this cost.
Shall I cover the 2019 costs?
Yeah.
So the last costs that came through, I have them in front of me, were roughly around as a net cost, £70 million of backlog maintenance was identified. There's a fair bit that needs to be added to that to cover elements such as VAT and design fees, but it's many tens of millions.
So these costs were not made clear in the business case as part of the usual business case when you reported it. So it makes it look that
well,
that you're not really serious about.
No, those costs have been are being factored into will factor into the new OBC. We want to get those costs updated because an awful lot has changed since 2019. You can see that there's a lot of investment that's happened into the estate already, so that will need to be factored in. Design standards, but part of the survey as well is about assessing the suitability of the buildings, and design standards will have changed, so there'll be some changes there. So we are looking to commission a new survey literally within the next couple of weeks, so I'd be very happy to come back when that survey is complete to give you the most up-to-date numbers. I think it's also fair to say that the construction industry has changed enormously, particularly over the last couple of years, with its risk appetite and suffering with inflation. So I think we would like to come and give you some accurate numbers when the surveys have been complete, hopefully towards the end of this year.
So would you roughly think that the new hospital is going to cost more than 500 million?
The cost for the new hospital is something that will be reviewed, as James has described, because the costing of the hospital will need to be updated with Hospital 2.0, which is the work that the new hospitals program is being developed to standardise construction techniques. So we will be refreshing as well over the next few months the cost model for the hospital with the NHP program.
So when will the actual business plan with all the funding and all the costs actually come out so that we can actually have a look? Because if you want us to scrutinise, we want to see what we're looking at. Not just, come back, we're going to do this, we're going to do that, because this has been going on for quite some time. I mean, the hospital should have been built by now.
I
And
mean,
now it's 2030. You could have built St. Heliers by now.
so
And the fact that you're saying that you're going to have cottage hospitals, and it all sounds wonderful, but that should have been done before you actually thought of building a new hospital, because then you could have decanted people in there, really.
So, I mean, I think there's a few things. I think the first thing is, Councillor, that the timescales associated with the National New Hospitals Programme are not entirely within our gift. We're working, we would like to work as quickly as the national team can work with us to finalise the cost envelope and the plans and when each other element will be delivered. And as I've said, as soon as we are clear on what we can share, we're very happy to come back and share it. And that will be the same with all of the scrutiny committees I talked to about this scheme, because there is a huge amount of interest from a number of everything scrutiny committees. I think it's important to say that the option that was selected was the option that was weighed up through the consultation process and through the decision-making business case as being the right option that addressed the needs of the whole catchment that Epsom and St Heliers serve, and was a joint process undertaken between a number of areas of the NHS. So I think that it's important that this is not a case of choosing a site at Belmont for purely building reasons over the rebuilding St Heliers. There was a much wider process that was associated with that, and I'm not intending to go back over that ground at this point. I think the other thing that's worth saying is I don't think we can compare the cost of tackling backlog maintenance issues and getting St Heliers to the point that it can serve its purpose as a district hospital with the costs of building a new major specialist emergency care hospital, because what we're talking about is a very different estate specification for those 6 major acute services, and it is some of the estate's challenge associated with running those major acute services into the future, which are simply beyond the gift of anyone to simply continue to update St Heliers. So I think they're quite different challenges, and it's important not to conflate them.
I think if I can just build on that, I think it's important to consider backlog maintenance is backlog maintenance. So it is to bring, it is not necessarily to improve the building, it is just to clear a backlog of repairs. It would not necessarily improve the performance of the building. A lot of the work that we have done has been to improve the performance of the building. It would not necessarily improve the functionality of the building. It is purely a backlog number. So I think, as James said, it's not quite comparing apples with apples, comparing across the cost of a new build with a backlog bill.
Yeah, you say that you're investing in parts of the hospital at the moment. So what I'm wondering is, does that mean that the rest of the buildings will be left to deteriorate, and obviously that would then have a detrimental effect on the patients before the new hospital is built?
No, it's we obviously do not have unlimited funds to be able to spend on these things. We have to make investment decisions that are on where we spend the money. Those decisions are almost entirely driven by patient safety and patient experience. So we do not want the buildings to be deteriorating significantly so that it would affect patient safety. No.
Just wanted to ask a supplementary. You're saying that, but the buildings have already deteriorated and continue to do so. They've been deteriorating over the last 4 or 5 years. And, you know, recently in the last year, there was a leak in the roof. So things are deteriorating.
I think it's worth saying that, you know, when we get leaks from, you know, there's a basic problem with the fabric of the building. And, you know, that means that we do spend a lot of time fixing things. So, you know, some of the most well-publicized leaks we've had have been in the maternity, in the labour ward, which is on the top floor of the women's health block. Those are promptly fixed. So they are fixed, and they're fixed as soon as we are able to fix them. Some of those fixes are very technically difficult. And sometimes we find that the fixes don't work for a huge amount of time because of the basic fabric of the building. But we don't, you know, but we are constantly looking to make sure that, you know, the services that we need to run on the St Helier site, we're maintaining them in a safe and effective environment. There are parts of the building that we have had to put beyond use for certain services. So we've talked about, you know, the decision that we had to make very early in my tenure around Beacon Ward. Now, the simple fact is Beacon Ward is subsiding. And it was, you know, Beacon was a renal ward, so it had dialysis machines, and those dialysis machines were moving across the floor because the floor was subsiding and there was a risk of ceiling tiles falling on people's heads. So, you know, we can't, fundamentally, there was, you know, this is a building with a prefab building with a 30-year design life that we were 50 years into. You know, we cannot go and fix. It's not an active decision to leave patients in Beacon Ward unless it deteriorate. There was no active decision available to us to fix Beacon Ward. It was beyond fixing, and it would never have been fixable. So the active decision we made was to bring forward our plan to move the renal wards to the 6th floor. Now, with some of the other renal wards that don't have that subsidence problem, we've put them to other uses. So in particular, Harry Seacombe Ward is now being used as a discharge lounge. It is fit to be used as a discharge lounge where it has medically fit patients who are waiting to go home. And we have refurbished it to serve that purpose. But it is appropriate that those renal patients are up on the 6th floor of the main block, because that is one of the parts that it is easier to repair and it is easier to maintain those standards within. So this is a quite active risk assessment, and in a lot of what is driving what we fix and in what order and how we fix it are the risk reports that we get from our services. We have a risk scoring, and that really drives how we set our priorities. You know, the first thing that we look at when we set our capital and estates plan for each year is where are our highest risks. And just to assure you, Councillor, that is what is driving how we then deploy the resources that are available to us to make sure that the hospital stays safe and effective. Thank you.
Thank you, Chair. I'll go back to the costs. It is stated that the cost of the making improvements should not be underestimated. But why are managers coy about giving those estimates, and how those will be funded?
I'm sorry, which costs are you relating to? The cost of the new hospital?
Or making improvements, yes. No, not new, the old one.
So I think we've detailed in information that's been provided. So I know that we've detailed in information that's been provided to Councillor
the challenges with old estates.
McCabe, the costs of some of the investments that we've made over the last few years, and the year-on-year investments that have been made in ESDH on that basis. I mean, I'm very happy to pick up offline in terms of any other specific information you would find it useful to see.
If I can just chip in, we are legally bound to publish our backlog maintenance numbers every year to the NHS that is in the public domain. So we're not being coy about those numbers at all. We can provide those for you.
It's not a question of you being coy about it. If it's in the public domain, and if you could sort of give it to us, so instead of us having to ask you questions, because that would save time, because there's a lot of things that we're lacking, and that's what we're saying. an estate inspection, we saw this big funnel coming down, and then a few months later, when cabinet member for health and scrutiny, healthy communities went there, the same funnel was there. So it was curious to know how long it takes to fix it and how long it costs, and if it would be possible to have at a future meeting, the estates manager come to the scrutiny meeting and explain. I know you've touched on it, but maybe help us understand how you prioritize and how quickly things get fixed would probably be helpful.
I mean, what I can say is that roof is now fixed. But I mean, I think it's fair to say, Andrew, the fix wasn't easy on that maternity roof, and it did take some time to get an effective fix. But that has now been rectified, and indeed we've had a number of issues with the top floor labour ward that we've needed to fix. They are not down to any lack of attention or dereliction or any attention to let it sort of deteriorate. They're simply down to the fact that, you know, it is an old building, and it is difficult to keep that flat roof watertight. So if there's further specific detail that we can supply in relation to the flat roof, I'm sure we'd be happy to do so.
Andrew, you touched on this earlier, talking about sustainability. With the Health and Care Act 2022, legislation obliges the NHS to comply with the net zero targets, and integrated care board and trusts have now published their first NHS Green Plans. Is there a plan for St Helier? What steps are the trust taking to ensure St Helier Hospital meets their requirements with regards to heating, insulation and retrofitting?
Yes. The board approved a green plan for Epsom St Helier about 3 weeks ago. So it's quite a recent document that will be heading into the public domain shortly. I am just establishing a group sustainability team to help come up with the plans that we will need across all of our sites to deliver net zero. The key target for us is to achieve 80% carbon reductions by 28 to 32. That is a tough target, but we hope with the BYFH program, that's an enormous step to being able to do that. So no, it's something that we are actively engaged in.
The conditions to manage COVID were not ideal in many hospitals. How did St Helier compare its performance compared to other places? And then why is information not available in this, and why is it therefore assume a new hospital is the answer?
I mean, I think there's probably need to answer that question in a number of parts. Obviously, the COVID pandemic presented a number of very significant challenges for all NHS trusts. I would say that some of those challenges for Epsom and St Helier were exacerbated by some of the estate's challenges that we have on both sides. In particular, the configuration of wards, bed spacing, in particular, presented specific challenges around infection prevention and control. So in hospitals that have more generous bed spacing in bays, or indeed have single room configurations, more single room configurations, it is obviously easier to manage different cohorts of patients with different infection status. And what that involved for Epsom and St Helier was a significant amount of sort of needing to what's called cohort patients and move them from ward to ward, and change the ward configuration throughout the pandemic based on the exact numbers. So, you know, how many COVID numbers did we have? How many non-COVID numbers did we have? How did we deal with people who we didn't know whether they had COVID or not, or had had a contact with COVID but weren't testing positive at that point? So, you know, the challenges around an estate about such as St Helier sort of really exacerbated some of those COVID challenges. Some of the responses were to look at our estate across Epsom and St Helier and use it in a different way. So we used our existing ITU. We also used the South West London Elective Orthopaedic Centre at Epsom, which is more modern estate with better bed spacing, and better ventilation and supplies and services as a COVID ITU, not just for the trust, but it actually took patients from the wider South West London catchment as well, because compared to a state that ITU could sit in right the way across South West London, actually Swelliot provided much better a state. So, really the response to COVID was about, taking what you have and adapting. So we had a COVID ITU at Swelliot that included our staff, it included St George's staff, and it included Royal Marsden ITU staff as well, whose support we were very, very grateful for, because it allowed us to open more ITU beds. So I think every single hospital had to do different things with its configuration to adapt to COVID. And we had to ask a lot of our staff. They were working in different places. We redeployed many staff into ITU in order to support the numbers that we had. But I think it was a good illustration of why ventilation, space, single room numbers, and modern ward configuration are really important. And we know that we can deliver those for our major acute services through having a new hospital. What information would be helpful to see, Councillor? So I believe that updates were given particularly to joint overview and scrutiny committees at the time in terms of some of the mitigating measures that hospitals were taking across South West London. I'd be very happy to ask our team to revisit some of those papers and to pull out some of the information that might be relevant. I think it's also worth highlighting that specific regard was given to the learning from COVID when the decision was made in terms of the configuration and the decision to adopt the decision-making business case in July 2020. So some of that information, some of that learning, particularly from the first wave of COVID, was available and was a factor in that decision. As I say, with those factors that I talked about, they were definitely factors, and it is our view that having the specialist emergency care hospital helps to address them. But in terms of some of those updates that were given to overview and scrutiny committees, I'm sure we can go back and look for those. So we're very happy to provide that information. I mean, I think from our perspective, everything that we have seen over the last 3 years has reinforced the need for a specialist emergency care hospital and for consolidating those 24/7 services. So there's absolutely nothing that we've seen through both the COVID pandemic and the subsequent recovery that leads us to think that configuration is wrong. In fact, I think in terms of the issues that I've highlighted for a major acute hospital, they are the right ones to be tackled, but it also reinforces the importance, I think, of retaining 85% of services that are currently on the St Helier site, because we know that actually those are the services that local residents most frequently need to access, and therefore it's important that they are local to the community.
Thank you, Chair, and apologies for lateness there. Sort of on reading the draft quality report for 2022-2023, it's not clear that the quality is less than good overall, or that it's really been affected significantly by shortfalls in the premises. Is that a fair comment?
I'm not quite sure about the precise part of that document that you're referring to. I mean, I would say that we've been quite open about the fact that challenges with the estate that we have do clearly impact on our staff and our patient experience, and do limit what we can do. But I think we've also been quite clear about the mitigations and also the need for us to reconfigure into a new estate. So I think that I'd probably say that in terms of our response to those issues, which have been well publicised, that's why we're, as well as addressing the most urgent estates issues with the current estate, we're looking to push on with our redevelopment.
Thank you, Chair. I would ask you a question about the new clinical model, as I've got some reservation on that. Do you acknowledge that it was never necessary to build a new hospital to justify centralizing A&E and emergency surgery? Or that reducing the numbers of acute beds, consultants and other staff will have an impact on local services? Or that the NHS will continue to have vacancy problems despite new buildings and programs? Or that there will be additional clinical risk posed by three-site operational model compared to two-site model?
So I think that the case for change that was put forward and the decision-making business case that was approved in July 2020 demonstrated quite amply that consolidating 24/7 services into one hospital would help to tackle some of our most significant workforce challenges. These workforce challenges are not unique to Epsom St Helier or South West London or Surrey, but what they are is exacerbated significantly by having to run 24/7 services twice. So I wouldn't accept that, and I don't think that's the case. And I think we've been through an extensive process that has shown that we will get benefits in terms of workforce sustainability from running 24/7 services once for a specialist emergency care hospital. And I do think that that reconfiguration is entirely necessary to put those services on a sustainable footing going forwards. So that would be, I think, my view in response to that.
We note that there's a new 6-facet condition survey being commissioned, but what we want to know is, can we see a copy of the 2019 version, please? And if not, why not? Because we've not seen that yet.
We'll take that on board. Yeah. I disagree with both statements. I think the Trust has been extremely diligent in terms of its management and addressing the issues that have come up. I think it's dealing with an extremely challenging set of circumstances and limited resources. I think the response in terms of the putting forward the case for change and the service reconfiguration has been the appropriate one. And I think the mitigations in terms of the issues that we presented today have been the right one as well. I would say that to infer that we are exaggerating these issues for effect would be completely wrong as well. We have been quite open about some of the issues that we face and how we think that they are important considerations for decision makers in terms of, you know, the priority of new hospital schemes across the country, because of course we understand there are finite resources, and of course I think it's important that we have the opportunity to make available to the public and to decision makers as well the challenges that we face at the moment. But I would absolutely refute the allegation that we have exaggerated them for effect. What we have done is simply highlight some of the challenges that we're facing, and that our very diligent teams, and everyone's talked about our clinical teams, but we also need to talk about the diligence, the professionalism and the discretionary effort that comes from our estates maintenance and facilities teams to maintain safe and effective services in an incredibly challenging estate. And I think it would be entirely wrong to say, in the context of the very hard work that those people do, that we have sort of sought to exaggerate things for effect.
Got one question. In terms of your communication between your residents or your young people, how are they like? Or are you able to let them know that there is issue around the building and this is why some of the services are being moved to another hospital? Is that something that our young people or your residents are aware of?
We have a patient panel. I think my observation of our patient panel is that it could always do with more young people on it. So I'd say the demographic of our patient panel is generally older. So I would be really pleased actually if we could look at trying to get some more younger people from Merton in particular onto our patient panel, because we do provide very regular updates to our patient panel, and I think that it would be a great opportunity to make sure that we're finding ways to engage more actively. And I think we're always very aware that, you know, engaging with younger people is you know, a challenge for a large statutory body, and we'd be very, very keen to find new ways that we could do that.
Could I second that, please? Because we have a specific process called PLACE, which I know is confusing because we use PLACE for a lot of things in the NHS, but it's about a patient-led assessment for the estate. So every year we invite patients around to come, and we would love to get some younger people on that. That'd be really good.
So
really full. We are alarmed, therefore, that the trust is proceeding with enabling to work prior to agreement of the business case. Is that so? That's what I'd like to know. Has this been funded by the NHS London, or is it at the risk to the trust? That's what I would like to know. Yeah.
So we have done everything that we need to do to proceed with reconfiguring services, and that was the process that we went through in 2020. The process that we are now going through with the National New Hospitals Programme is to look at the sequencing and the phasing of the work to deliver on the decision that was made in 2020. So the decision to proceed with the specialist emergency care hospital has been made. This is simply a process to say, what do we do in what order? And in that sequence of things that we need to do, there are enabling works that we need to deliver. And that's why it's so important that the Secretary of State has reconfirmed the commitment to deliver the scheme that has already been agreed, that all the decisions have been made. So the point about the enabling works is simply for us to submit the necessary paperwork for us to proceed with delivering the agreed scheme. There is not another point of decision in this process. This is now just about the sequencing and phasing of delivery.
What would you do if a new government came along and changed your project? It's not really about, you know, sequencing. You have to consider all these things, and we are worried about things like that.
So I mean, ultimately, I'm a public servant. I'm not elected, and that is not a matter that I can influence. What all I can do and all I will do is, you know, continue to assess the need to deliver this scheme and continue to work to deliver it. Typically in the NHS, major hospital capital programmes deliver across multiple governments and deliver across changes of governments. And I have been involved in schemes in the past that have needed to deliver across multiple governments. And, you know, we've noted that, you know, that would note that any incoming government may want to review its capital programmes, but equally, I think our belief would be that our business case stands up, and that the need for the specialist emergency care hospital would be evident to anyone who looked at the scheme.
Thank you. I'm interested in the. I mean, I listened to the announcement by the Secretary of State for Health on the 25th. I also listened very carefully to the response from the Shadow Secretary of State for Health. And one of the things I don't think I've heard anything that kind of reassures me tonight is the issue of inflation. When this hospital was agreed, the business case was agreed in July 2020, we have had an awful lot has happened in the world since then. We've had 3 prime ministers for a start off, but there's been a huge increase in building materials costs and labour costs, and yet there is this continued insistence that a project that was going to cost approximately 500 million per hospital can be done for 80% of that. There was a report in the Health Service Journal about that about 12 months ago, pointing out the inflation. And to me, there just doesn't, the money doesn't add up. And yet we appear to be charging on regardless, even though the Audit Commission has made a clear recommendation that with projects of such enormity, that you should review before proceeding and ploughing on regardless. And I don't see any willingness to do that. And I'm really interested to know what can your colleague, perhaps you're best placed, what is the rate of inflation in the period from July 2020 to the current time, and what will it be when we get to actually putting the foundations in? Because that's not going to go away. And anyone who's ever employed a builder and has asked them if you can do the job for 80% of the price that we originally thought, will find very quickly that builders will tell you, yes, we can do that. You'll get 80% of the building works done. And the notion that somebody, like you pointed out in your presentation, that the NHS has been going for 70 plus years. In all that time, nobody has thought about this modular building. None of the Secretaries of State of all the political parties have come up with an idea to build hospitals cheaper. And yet there is this insistence that all 40 hospitals promised by Boris Johnson, and he has made lots of promises, will be delivered by 2030. And I think there's a real sense and anxiety that the money isn't there. And even if it was, so much has happened, and this absolute refusal. I mean, you constantly say, James, that we've made the decision, we're not going back on it, we're not looking at it, and that's completely contradictory to what the Audit Commission is recommending with projects of this size.
So, I mean, in terms of the challenge about the Secretary of State's assertions around the overall cost, I think you need to direct them to the Secretary of State, and I'm absolutely not going to start unpicking the assertions that have been made by the Secretary of State for Health on the floor of House of Commons. That's not our point. That's not our place. He has committed to us and to the public that the scheme will proceed and it will be fully funded. The new hospitals programme have worked with the Department of Health and Treasury to make a number of calculations in terms of the overall affordability of the programme. Obviously, we're not privy to those assumptions, and I am not going to sit here and speculate on what those are, but they have been made, and there is a commitment within that our scheme is fully funded. I don't know if Andrew is in a place to answer the specific question about construction inflation, but what I would say is, we've continued to look at what we've learned coming out of the pandemic and through the elective recovery, and there is absolutely no evidence that suggests that the decision we made in 2020 is in any way not still the right one. And it is incredibly important that you can plan these schemes with a degree of certainty. If we revisited every single major capital programme in the public sector mid-flight every 2 to 3 years, we'd never build anything. So I think that we will continue to work really closely with the new hospitals programme, who will of course want to review all of the assumptions in all of the 40 schemes. But our evidence to that programme will be this is still the right configuration, and everything that was in that decision-making business case still stands. Thank you.
What steps have been taken to identify other successful 3-site configurations, or indeed what steps have been taken to confirm that acute capacity will be able to absorb the additional demands of an increased elderly population in less capacity, given an increasingly dysfunctional primary care and community care system that is currently fracturing?
So a number of assumptions were made and a number of sensitivities were worked through as part of the original business case. We would expect to continue to review those assumptions with the National New Hospitals Programme as part of the confirmation of our element of the scheme as we proceed to final approval. So, yeah. That's all I have to say. Councillor, I'm very sorry, but I did say I was on call. Unfortunately, I've been summoned to an urgent system call at 8:30. I'm sorry to bring forward the schedule a little bit, but I think it's due to exceptional pressures.
Thank you very much for coming along. Okay, can you just ask one question and then you can quickly, because he's on call.
This decision to move it to Belmont, what impact on, in 2017 to 2020, over 68,000 attendances at St. George's have been from residents living in Epsom and St. Helier Trust. It is highly likely that other residents in this area of the catchment would turn to St. George's instead of Belmont if the proposal goes ahead. What would the impact on St. George's be if the move goes ahead? Would they not be overwhelmed?
So the impact on St. George's was assessed as part of the original consultation, and specific capital is intended to be made available to St. George's in order to mitigate the small impact in terms of additional attendances and deliveries as a result of the slight change in the border that was identified at the time. So very robust travel modelling was done to support the original decision.
Because he's got to go, he's on call.
A very quick supplementary question to that. I'm concerned about the impact on Croydon University Hospital and Kingston Hospital. So have those been assessed as well?
Yes, so we assessed every bordering hospital: Croydon, Kingston, St. George's, Ashford, St. Peter's, Guildford and Sash were all assessed as part of that piece of work.
Thank you very much for coming along. I'm sorry you have to go because we do have a lot more questions on the impacts of other hospitals, which, we've had a look at, and there's quite a sizable impact. There's not of a positive nature. So I think, you might have to go back and have a look at it because none of us are really convinced of it. But as you have to go tonight, I will let you go. Being on call is not easy. I've done night duty before. So, thank you very much. So please, whenever we do have a recommendation and we send you a report, please do give us the right information so we won't have to sit here ask queries, asking you all these questions for such a long time, because if you have the information and the data, everything will be half as quick. Thank you very much. Thank you. Right. I'll have to actually go back to the beginning of the agenda. Are there any apologies? Any apologies? No, okay, all right. Declaration of any pecuniary interest? No. Minutes of the previous meeting? Have we agreed? I had to try and get
Agreed.
try and get James and his colleagues in quickly because he was on duty, so I sort of missed the initial one, so I've come back to sort of complete it. So now we'll we'll be going on to the adult immunization. Who's going to present that? Oh, they're online. Okay. Yeah, we'll give you at most 10. No more than that.
Can you hear us?
Will be good, so we can ask you questions.
Perfect. Can you hear us?
Yes, we can hear you.
That's great. So good evening. I'm Ryan Grocock, a public health registrar at NHS England, and I'm joined by my two colleagues, so Susan Alden, who's a consultant in public health, and Eleanor Walker-Todds, who is our immunisation commissioning manager. So this report that you've seen covers adult immunisations commissioned by NHS England, and these are a subset of the wider vaccinations that we commission across the life course. So as you all know, vaccination is an important and effective public health measure to both reduce the spread of disease in our population and also reduce the burden of complications from disease to the individual. So the adult schedule includes 3 vaccinations. So there's a PPP vaccination that protects against pneumococcal infection. And these infections can lead to pneumonia, blood poisoning, and meningitis. And all adults over the age of 65 and those with long-term conditions are eligible for this vaccination. The second adult vaccination is shingles, and this is caused by reactivation of the chickenpox virus. This isn't contagious, but the vaccine helps to reduce severity of the disease if it does occur. And this is available on the NHS to adults aged 70 to 79 years of age. And the third vaccination that's available is a flu vaccination. That is a seasonal vaccination that we offer every year to those aged 65 and above, and also to those with long-term conditions. Again, this helps reduce the spread of flu within the population and also reduces the severity of the disease if flu is caught. So in terms of coverage, historically and currently, London performs lower than the national average across all our immunisation programmes. And there's a multitude of reasons for this, but it includes that London has a highly mobile population, a large migrant population, and also areas of high deprivation. So in terms of our vaccination programme, we're not just concerned with overall uptake, but also equity and uptake. And as you can see from the report, there are marked differences in uptake across the vaccination programs between groups, and these tend to mirror patterns seen in inequalities for wider health outcomes. So I'll summarize some of the key points for the data for Merton. So in terms of flu, overall uptake in Merton is similar to the rest of London. It's slightly higher than Southwest London for those aged 65 and above, and similar to Southwest London for those with long-term conditions. In line with the national and regional trends, the uptake in flu has decreased over the last 3 years, and this follows the significant increase in flu coverage during the COVID-19 pandemic. Referring to the chart on page 13 of your bundle, we can show that uptake of flu varies significantly by ethnicity. So if we look at these circles, then this shows ethnicity, percentage uptake by ethnicity. And we can see this is lower in Merton for both Black and white other ethnic groups. We can also see in Merton that uptake of adult vaccinations also varies significantly by deprivation. So on page 14, we can see that there's a gradient in uptake by deprivation, with those that are least deprived having the greatest uptake of the flu vaccination in Merton. And we can also see that visually that in the east of the borough, which is more deprived, uptake is lowest. For PPV, uptake in Merton is 65%, which is slightly lower than the London average, and this has remained stable for the last 3 years in Merton. And for shingles, finally, uptake is only 33% in Merton, which is lower than the London and South West London average. So some of the challenges for vaccination programs and adult vaccination programs in general include disruptions to GP services during the pandemic, leading to missed vaccinations, issues with accurate data collection to ensure that the population registered is accurate and that vaccinations administered by GPs are accurately coded by practices to then be picked up by our data sets, wider pressures on access to GP appointments, and also a feeling of saturation and fatigue of vaccine offers following the COVID-19 pandemic. There can also be some issues around awareness of the adult schedule and wider vaccine hesitancy and disinformation towards vaccines. I'll now pass over to my colleague Susan, who will discuss some of the key responsibilities and work done by our system partners to improve uptake in Merton.
Thank you, Ryan, and thank you very much to the Merton Council and all the colleagues who invited us, and also really want to thank the committee for your attention to immunization, because this is something that's very important to us. So I think we get an opportunity to talk about child immunization tomorrow as well. I think from our perspective, Ryan gave a highlight of where we are with the adult overview, but I think the background and what a lot of you know who've been working very closely with the communities of Merton is, the backdrop to this prior to the pandemic is we have a lot more vaccines now than we ever had. The schedule changes frequently. And I think, as colleagues also know, the health system is under quite a bit of strain. So I think the overall summary, if I would have to summarize performance overall, is we would say across London, it's below the England average, so we are not happy with that, and it's below our target average. And with Merton, it's a bit of a mixed picture where it is relative to London, but I don't think any of us are satisfied with the performance, and we're doing a number of things to look at how we can continue to maintain and improve that performance. The two key areas I would highlight that we're really laser focused on is coverage and equity. So you can see that coverage has either plateaued or is starting to do a bit of a downturn on some of those. And so it's important that we look at ways where we can actually boost that coverage up through our better planning. And again, also bearing in mind that flu is seasonal. So some of this is when the system gets the information, when we get the doses, when we get the funding, we're starting that planning right now for the winter season. But as many of you know, like the COVID spring booster is happening now and with vulnerable groups. So there's different schedules in the system, different system pressures and performances. So vaccination has become more complex. It has become, much more across the life course. And Ryan's also mentioned sort of shingles, pneumococcal and other things. There's also a lot we need to do with communities directly around awareness. And so even within Merton, what we need to be thinking about on the equity front is thinking of those pockets of deprivation, working much more closely with our integrated care board colleagues and the local authority on how we work within the populations where that uptake is lower. And we can see that, perpetually miss groups over and over again. I think that there's also a thing to think about in terms of flu and shingles, particularly, is there's a perception sometimes amongst some communities, and I put some of my own older family members also just to sort of use that is, the current shingles vaccine that we have right now is 1 dose and it's a live vaccine. In the autumn term, we will be moving to a different vaccine, which we hope has fewer side effects, but it is a 2-dose schedule. So there is things around the schedule changing. There's sometimes confusion with people, or there's talk of side effects and things like that. So we also want to think about, what that means, the reality for individuals. But I would just kind of leave you with what we're doing is about planning our flu winter season now. We're thinking about the cohorts, how to reach those missed communities. And also on the back of that, we have a number of different campaigns that we're planning for the autumn and winter months. But we'd be particularly glad to hear from you on what more we can do, because I think the overall assessment from our end is, performance is maintained, but we think that we can do better on adult immunization. So keen to hear from you on what you would advise for us to do going forward. Thank you.
Thank you. Patrick.
Thank you for your presentation. It was interesting to see here, but I'd be interested to know about shingles, because I don't think there are a lot of people out there aware of the shingles vaccine, and I don't know how it is communicated to people. And do they have to have shingles before they can get a vaccine, or do they automatically get one at the age of 70? I mean, whose role is it to communicate it to the general public?
So I can answer that one. So the shingles.
Sorry, I was actually going to get 3 questions for you. Okay, sorry, I should have told you.
My question is, in terms of the immunization tables, you said pregnant women. Does that include young people that are pregnant as well, in terms of the immunization, or is that just only for over 50s or over 40? And then another question I've got is, in terms of information, you said you advertise your information on your website. In terms of the over 65 or over 50 with technology and smartphone, how are they aware on where to find this information? If it's on the website, and most of other people might not be able to use a phone or navigate around this website. So how are you communicating with them better in terms of the immunization? And then also, you said that there is a low engagement in terms of medicine. What are your work in terms of increasing those awareness, or what are your plans in terms of engaging more with the young people? Because the young people are not really aware of those immunization or what age they have to be in order to get those immunization. So what are your plans around those?
Yes, thank you. Sorry, I'm a bit concerned we're going to be overloading you with questions here, but I've just been surprised that we've just been asked what we think you should be doing. I mean, at a high level, I could say that the underperformance with respect to vaccinations, particularly amongst the Black community, is deeply disturbing, and that has remained consistently poor for too long. I'd like to know what you've done already to improve the vaccination rates. I'd want to know what other boroughs are doing that mean they get better performance. And I want to know what other new efforts you've got in the pipeline. I don't think you want us to tell you what the effort should be. I'm asking you what the effort should be to significantly improve vaccination rates, particularly in the Black community. Thank you.
Got 3 questions, so you can respond.
Chair, I would just ask to expand the question on Black communities to the white others as well.
3 questions, so you can come back up.
Okay, so shall I have a go at answering?
Yes, have a go at your 3 questions, and I'll come back with some more.
Okay, so first of all, thank you on the shingles awareness. So first of all, no, we don't want anyone to get shingles. You know, they should be alerted through their GPs. There's also a number of different things happening through local community centers and different initiatives with older groups and with care homes, depending on the age of the cohort. So it should be through both the primary healthcare system as well as wider community efforts. And also some of the roving teams that are working with flu and COVID are also bringing shingles into that. Although currently, because shingles is a live vaccine, it is given separately than the flu and the COVID, but that is going to change. I think that covers it on shingles. On the pregnant women, yes, it's for pregnancy, we do a different set of vaccinations, and that is both to protect the pregnant woman in the pregnancy period as well as the newborn. So one of the ones that we do for that is pertussis, which is whooping cough, and it tends not to be deadly, but it is something that we can, again, prevent from passing on to infants. So that's an important vaccination. But the age of the pregnancy, it isn't a sort of, that there are certain ages, although we do have to look at, risk factors in older women and that sort of thing. But it's the pregnancy is about protecting the newborn and the mother during the pregnancy period. Great point you're making about technology and working with older people. Our colleague Fiona and Julia Groom from the public health team, and Dagmar, who's the director of public health, can talk to you a little bit probably about some of the things that we're doing, because particularly we have to think about people who aren't like non-digital ways of reaching people. What we find with our younger people is that social media, things like Snapchat and those kind of areas are more helpful. But with older people, again, it's a bit of a mixed picture. So what we want to do is communication both through the existing systems as well as through the various social networks and the various outreach activities. A great point about younger people, and I know that there's a meeting tomorrow that we're coming to look at children and young people in the Scrutiny Committee. But yes, engaging young people is of particular importance. And just today, maybe one to highlight is we're doing the HPV vaccine, which protects against cervical cancers and other cancers, and that's going down to 1 dose. So that's another great achievement, we think, for the population, of moving from a 2-dose to a 1-dose schedule to eliminate cervical cancer and other cancers. And then the last councillor who was mentioning about what efforts we're doing in the Black community, and first of all, maybe to offer my apologies when I said, what would you like us to do and what are you doing? I think my sentiment, and I'm probably not very articulate, so I'm sorry if that came across rudely, but I was referring to the fact that, ourselves and NHS England, so you're talking to us and we take responsibility for the region, but we work very closely with our integrated care boards. Now, the reason I sort of ask this is I'm not as familiar with the local level communities of Merton. And so how we work very closely is with the local authority public health teams, with hearing back from council meetings like this one and with other ones of actually saying what we need to do more and better, because our instruments through schools, through primary care networks, through the roving teams do some things, but they don't always capture the nuance of what's very particular about Merton people and Merton residents. So with regards to the Black communities and some of the missing populations, we have the Inspire Black Africa Caribbean Health Network, which does outreach particularly on flu and COVID, and with older age groups. And then there are other ones where we work with religious and ethnic groups such as Eat in the Square, and then we try to time it around campaigns or things that are related to religious festivals, as well as using local community groups who already have champions in the area.
Thank you very much. I'd just like to ask you a bit more about pharmacies, because obviously for a long time they've been working to sort of roll out vaccines, and that's been increasing over the last, certainly since COVID. So that seems like a great way, because a lot of pharmacists are still seen, as a great community asset. They're family owned. I mean, it's predominantly pharmacists. There's a few top corporate players, but otherwise they're predominantly small pharmacists, 1 or 2 or 3 owned by someone. So they're a great community asset. And to me, that seems a really sensible way to try and roll out more vaccines, try and sort of promote some of these vaccines as well. I mean, I myself, like my fellow councillors, wasn't aware of some of the vaccines you were discussing that we can actually deliver. So is there something around marketing in pharmacies? I'd love to hear more on that. Thank you.
Thank you, Chair. I would like to expand on wide other communities. The bar rising up to 40%, and we know that the wide other communities are invisible in core 20 plus. So what steps have been taken to actually reach those communities and make sure that they've got access to healthcare?
Further to the comments from my colleague, Tony, actually, you've in your background information, you say the greatest impact on the world's health is vaccinations is also one of the most cost-effective and public health interventions. So really, we just to hear tonight that you know, we're falling behind on all of these in the data is really troubling. One of my questions I'd like to ask: are the immunisations for asylum seekers, are they included in the programme? And also on the challenges that you mentioned, you're talking about access to appointments, data collection, reminder systems. It all seems quite sort of straightforward, a way to look at improving on these immunisation. And it says the lack of awareness of immunisation schedule. I mean, that's a simple comms issue. So with all looking at all of these, what improvements have you planned? Thank you.
Why don't I take a combination of those, but I'd also want to talk to members of the team, Ellie and Ryan, and also if other folks who either have a GP background or folks in the room who might also have experience, I'd be happy to bring them in as well. So it's a wider perspective. But firstly, regarding the comment around community pharmacies, I think that this is an excellent point, and this is something we're really maximizing. And what we think is that the easiest way to do this is through the seasonal vaccines, because that is something that we can offer at various time points, and then there's convenience, and that's a lot easier. It's tougher sometimes for pharmacists and other people to work in the routine childhood schedule or with adults or things where there's multiple doses, but when they're one-off schedules, that's something we're definitely rolling out across community pharmacies. There are training aspects, and there are certainly things around cold chain and the business model, but I'd have to look at the statistics for Merton, but I think that particularly in Southwest London, there's an expansion going on, and it's going very well. And I think there's a real appetite with community pharmacies, not just to do vaccination, but to do other health checks as well as that. And so the important thing is that we do the vaccination with the community pharmacies, as well as have an interface with the primary care so that people can be referred into their doctor if there are other health needs for that. On the white other comment and the core 20+5 and languages and what else, there are things that we're doing around interpretation and you know, how we're doing that communication. But if I could hand over to Ellie to talk a little bit about the ethnicity project and how we're looking at basically what we do know about ethnicity and how we're looking to engage and across all of our inclusion groups. Ellie, could I call on you to talk a little bit about that? And maybe the asylum seekers as well, which I think is a great point.
So firstly, one of the questions was around asylum seekers and whether they're included. They are all included within the immunisation programmes and all can access those. And actually there's heavy outreach that is done within those communities locally and also across the region. We do commission an organisation called Find and Treat. So they're a roving team, and they deliver certain adult immunisations specifically to health inclusion groups. So that includes refugees, asylum seekers, your homeless population, you know, Gypsy, Roma and traveller communities, etc. So those communities who may not access healthcare via some of the usual routes, especially primary care, and need that sort of little bit of extra time spent with them to explain what the vaccines are and have the translations, etc. In terms of languages, so we have completed a language audit regionally, which consisted of sort of understanding what we already had that was translated, specifically for flu and COVID, and then where the gaps were. So that was working with our care boards across the region, finding out specifically that kind of local intelligence, which Susan was sort of referencing earlier around understanding from you guys that kind of local, really hyper local information about, you know, which languages are we missing, who needs additional translated materials, what does that look like, and then we collated all of that and pushed that back to UKHSA who produced those materials. And then in terms of ethnicity, it's really interesting that you brought up white other, because that's a specific group that is really challenging, because we don't have the data breakdown on who is included within that. So we work very closely with our local authorities, but also with our integrated care boards to understand what white other communities look like within those boroughs and those spaces, so that then we're providing the right healthcare. But it's very much a sort of partnership approach. And then overall, we've done a project which we've started and is ongoing. So looking at ethnicity and its recording. So at the moment on the systems, there's a way to record ethnicity unknown, but then also ethnicity when someone doesn't want to state it. And as you could see from the data, there's a large proportion where we don't know people's ethnicity. And so we've worked with certain GPs throughout the London region. So we picked out 320 as an initial sort of pilot to go back and work with their population groups to obtain that information, so that then we can have a much more targeted approach. To be honest, outside of immunizations as well, you know, it affects the whole of the healthcare system, which is fantastic because it will have huge impact. But to make sure that we really know who our communities are through the data. So I don't know, Susan, if there's anything else you want me to add to that, but initially the success of that was fantastic. You know, within the first few months, we were looking at over 67,000 additional ethnicities being added onto the system just from the 320 GPs that we were working with. So that is ongoing with primary care colleagues.
Yeah, and I just want to point out, you know, when we're talking about ethnicity and we're talking about, you know, race and things like that, and some of the conversations we've had in the focus groups is some folks have told us that actually they don't feel necessarily comfortable being targeted or ticking the box, or, you know, is it because their ethnic group, you know, that we're sort of chasing them down for vaccination? And I think we have to apply a real sensitivity to this across all of our primary care services. And you guys are going to talk about screening, because I think there's a similar trend here is, you know, we need to think about how we're providing inclusive healthcare that people want, that is responsive to their needs, rather than them being targeted for one-off campaigns or saying, you know, this is what we want you vaccinated for this reason. And so I think it'll hopefully come to light a little bit more in the screening conversation. The other conversations you're having is we need to make sure that we have a really solid offer that is inclusive, that is open to people, and that people feel that their services are accessible and meeting their needs, regardless of whatever their color is or whatever their background is, but that we are an open and available service there for their overall health needs, rather than saying, we want you to get this vaccine or we want you to do this for our particular targets. So there's a nuance with it where we really want to respect communities where they're at their starting place, and really encourage them to do a number of things that's good for their preventative health, not just vaccination.
So it's another question. In terms of the school age immunization, in terms of school knowing which of the young people have all of this immunization, how are those data being recorded? Because some of our young people do move schools and they do move placements. So most of the school might not be able to like communicate with other schools to let them know that they are vaccinated or they've not. So how are these being recorded, or how are you being, how is this tracking? And then also in terms of the Black ethnicity, I think a lot of the issue around this is information, because in terms of the COVID-19, we find out that a lot of them were not planning to take it because they had a negative information about it, or something bad will happen, or if you're pregnant, or your baby will die, or something like that? How are this information being provided so that they know that, okay, this is actually what are the side effects, or these are why the vaccine are really important?
Can I say thank you for making that last statement, because I wasn't going to say anything, but since you said it, a lot of the Black community are actually fed up of being told that they're the ones that are not taking the vaccine, when you actually look at the real stat, they are taking the vaccine more than the other groups. So, and people feel that if they don't need the vaccine, if they don't need the flu vaccine, why should they take it? Not everybody takes flu vaccine. You go to your doctor and they tell you if you need it, so they'll give it to you. And the shingle is only sort of a new thing. Not everybody needs a shingle. So I think with all these things going on, they should stop trying to make people feel guilty just to try and get their vaccination program going. But people are absolutely fed up. And I know for sure that people, especially in the ethnic minority, they are sick and tired of being, used as a scapegoat just to make sure the ticking boxes are done. So thank you for saying that. Share.
Should I comment, or is there another question?
There's one more. Very nice. Yeah. Try and speak. No. Yeah, just try and speak. It's not going.
Oh, there we go. Hi, just wanted to contribute by saying that I think it's really important when we discuss Black and ethnic minority groups to recognise that Black and ethnic minority groups are not one homogenous group. There are Black communities, there are brown communities within that brown community. I myself am a Caribbean community, Caribbean brown, Indo-Caribbean is the correct term. And there are discrepancies within Bangladeshi communities, within Pakistani communities, within Indian communities. So I was wondering if you could talk us through the stats in terms of the breakdown of those specific ethnic groups, because I completely understand what the chair is saying, that the take up in Black communities has been a bit higher than sort of, for example, Afro-Caribbean communities and Indo-Caribbean communities versus Black African communities. So I was wondering if you could talk us through those stats and any key differentials that you've observed yourself. Thank you.
So why don't I have a go at the first question? Then I think that there's a wider thing around ethnicity, and I think we need to be really careful that the data tells us some things, but it doesn't tell us everything. So the biggest issue that Ellie highlighted is a lot of people don't feel comfortable recording their ethnicity, and again, it's self-reported. So what you call yourself as a white other, or as the last councillor was noting about, that Black and brown communities are very diverse. And so we need to be very careful about not being reductive and overly compartmentalizing on that. But maybe just the first one around the movement of school age IMS and the capture and the record. What we do is, so in young people, and right now happening across the schools in Merton, there is a polio MMR campaign. So as you know, that there is still poliovirus in the sewage of London. And so we're catching up all of the children who haven't had polio or the measles, mumps, and rubella. And so we're calling parents, we're offering additional clinics. Now, those children should be recorded from their school data, but they also have a record in their GP. So if they're not called from their GP, they should have it on their school record. We have another bit in the middle called the CHIS, which is the Child Health Information System. So what we are doing is triangulating across all of those, because as the councillor rightly pointed out, children and families move a lot in London and in Merton. So what we want to do is have all three of those data systems saying, can we still maintain and see if we can find those children? Because a child in London could move 3 or 4 times. And also we find that sometimes more vulnerable communities are people who are homeless, people who are travel communities, various ones do move a lot. So it's important that those data systems join up. I think the other question was about how we use information in social media, how we counter the, some of the negative impacts. And we do see this particularly. So I think that what we try to do is what we find particularly with older people. And again, it depends upon the vaccine, it depends upon the group, and we need to not be too reductive, but the trusted sources of information tend to be the doctors, the nurses, the healthcare providers, and even the NHS website. So what we try to do is produce factual information that is there to clarify, and social media, but making sure that it's branded appropriately as NHS. Ellie, there was more on some of the last comment about, the nuance and what we see on ethnicity, but I think this is kind of your specialty. Do you want to come in on that?
Yeah, sure. I mean, it's quite a challenging question, and I wish I had a sort of stronger answer for it. So some of the groups that you mentioned earlier in terms of ethnicity. So when you're in your GP and you fill out the form when you're registering, there's a list of ethnicities on the back. And that is a standard list that is used nationally. So we have fed back around expanding that list, but there is the option obviously to record other. However, that's very, very infrequently used. So in reality, the only way we can break down ethnicity and look at that across immunisation uptake is based on the list that we have there. So we can't readily speak to that. The only way that we are able to speak to that is when we work in partnership with our colleagues. So for example, immunisation coordinators and again, public health colleagues who are working directly with those communities, but it's more anecdotal. It's not data-based because we just don't have that source of information. Hence why, for example, the ethnicity pilot that we spoke about earlier is so important, so that we can get a realistic view. And again, similar to what the chair was saying, it was showing lots of specific communities were underreporting in terms of being vaccinated, but actually, is that the true picture? And that's the question that needs to be answered, which we're currently working on. I think the other thing I just wanted to also say, which is from the first question, around record keeping as well for school age immunisations, is there are very robust processes in place from our school age provider teams to make sure that any vaccinations given in schools are put onto the GP record incredibly quickly. It's usually within a couple of days, so that there's reduced risk in terms of something not being recorded or someone being called in for a vaccination that actually they've already been given. And it's very clear in terms of the contracting lines between GP and between school age providers, so that nobody's being double vaccinated or missed, and everybody understands the process and who should be vaccinating, who takes responsibility, where the data flows to, and where it needs to be reported to.
I just wanted to say that the chair really captured the sentiment. You really captured the sentiment, I think, that we're hearing in terms of vaccine fatigue and, people sort of talking in sort of more patronizing tones about things like this. And so I think the sentiment I was trying to get across is it's as much as asking and listening. What do we need to be doing differently? What do we hear from you? What do you want to protect yourself? And my colleague Jill Rwande is in the audience, but she's also looking at screening. And so some of the bit on ethnicity, I think that's important is, a first generation person versus somebody who's lived in the country versus, bilingual, multilingual households. There are various needs. And so one of the things we find, like particularly with the Asian Indian community, they want the BCG vaccine to protect them against TB. They may or may not want another vaccine, but they may or may not want other things because their own life experience. So I think the other thing we have to do is look at this not as in terms of just who you are as an ethnic person, but what has been your experience of NHS and understanding how the health service works for you. What's been your interaction with nurses and doctors, and how comfortable do you feel in those settings? And how can we reach you outside of those settings, such as the community pharmacies and other places, to make sure that all of these services to protect you and support you are accessible to you in a way that makes you feel most comfortable. Over.
Thank you very much. Tony, last one.
Okay, thank you. I'd like to come back to where I was, which was, my personal view is that frankly, this is consistent underperformance in Merton. I don't think it's acceptable that we have such a low level. You comment on there being a highly mobile population, large migrant population, high deprivation. I don't know if it's any worse here than it is in, but it isn't any worse here than it is in other boroughs in London. And yet we've got such poor figures in this area. You've talked about some of the things you're doing, but clearly if you just carry on doing what you're doing, you're going to carry on getting the results you're getting, which is underperformance. I'd like to hear, and I'm not getting a sense that the figures are going to be any better next year. Seriously, I don't. Because I'm not hearing that you've got anything new in the pipeline that you haven't already tried. That's going to generate much more better statistics, better figures. I'm sorry to say that, but that's honestly what I'm thinking.
Do you have a response or no?
Yes, do you want me to respond to that?
Yeah, he was the last. Tony was the last one. We'll give you a break.
Okay. Look, I think it's a very fair comment. I mean, and I think that this is why we really appreciate coming here, is because, you know, we aren't satisfied with performance. So I don't know of a single borough or region that has reached the standard. But what I would say is, you know, it is about these conversations. So what are we going to be doing between now and next year? There are things we're doing as a system to make sure that we're capturing and identifying the groups where we can through primary care. There's also the outreach of the people that are missed through the traditional settings, which I thought that we talked about a little bit with the ethnicity project, with the asylum seekers. We have roving teams, we have pop-up clinics. There's going to be additional sites through the integrated care system and the local authority in terms of outreach. I mean, I'm happy to go through some of the specifics on that. Will it result in greater uptake? I think that that's a question mark. What we have seen is a national downturn, and these are mostly seasonal, again with flu, shingles and pneumococcal. We have seen a downturn partly because of what we think is probably vaccine fatigue in the communities. And we have seen, you know, some of the plateau because people are making a decision about whether or not this is something that they want. So again, we make that offer, but we are not, we do not take a view of having it mandatory. So I think that there's something about making that offer, but making sure that it's not forced upon people, and that it's part of a wider offer. So I guess one of the things I'd like to do, and one of the things we are doing, which will segue into the next conversation, is making sure that we don't just talk about vaccination and isolation, but we talk about screening, access to primary care services, and wider things, because I think we will find that a number of health services are under strain and are underperforming at the moment. We all feel that we can do better. We have workforce challenges that we're doing, that we have as part of this, but happy to come back and talk about whether those are meeting those for the people of Merton.
Susan, can I just jump in off the back of that as well? I think it's also worth mentioning the national and regional immunisation strategies, which are very near to being published. But also the impact that that's having locally, because I think, you know, for me, I've gone to a lot of the meetings which the Integrated Care Board, so South West London, have been hosting within each of the boroughs. So very recently they had a meeting with Merton to talk about an immunisation strategy for the borough specifically that will feed into then a South West London strategy. So it was looking at what are the specific needs and issues that need to be addressed in Merton. And again, that's due to be published in the summer, late summer. But I don't know, Susan, if you want to come in around sort of the umbrella strategies that all of that will sit underneath and how that's going to impact immunisations.
Yeah, so I think that's a great point. So there is a national immunisation strategy, which is due to be published in July. There is a regional one again, coming out in July, and then the Southwest London, as well as the Merton immunization strategy. So the important thing that we look at through that strategic and that action plan, I wasn't really talking, I was talking more about the delivery, but I think that there is something where we're looking at this performance much more broadly. And we're talking about four main components, particularly for London, for Merton and Southwest London. And this is about workforce, so improving the training, looking at greater visibility, having immunization coordinators bridging those systems, community engagement, not just through the outreach activities, but what we're calling, excuse me, in-reach, which is building onto other services that are already there in communities, such as the Black Inspire Network, or other health and community things that we can tap into that are already there. The other theme is around access, and this is again, not just through community pharmacy, but nurseries, but a range of community settings, making sure that vaccination is more accessible, more opportunistic, and more readily available. And the last one is innovation. And innovation is really about thinking about the new areas, the different ways that we can join up data sets, using the NHS app and some of the digital tools, which are appropriate for some, but not appropriate for others. But again, thinking about different ways of working to reach people in ways that are not in the traditional ways. And there's a number of pilots happening in Merton as well as in Southwest London, which we can provide you some of the details, not just of the pilots, but the things that are being scaled up over time.
Thank you very much. Thank you for your time. And it'll be good if you could come back with an update with a bit more data and see how things are moving along. So anybody else with anything? No? We'd like to thank you for coming, and we'll be grateful for your update soon. Good night.
Thank you.
Thank you. Thank you.
Sorry for keeping you so long. Are you ready for us? Okay, we're on item number 5.
There we go. Thank you. So my name is Josephine Rwenda. I'm a consultant in public health and the cancer screening public health lead for NHS London. And I'm here to give you an update on cervical and bowel cancer screening in London, Southwest London, and in Merton. So in terms of our role as NHS England, we are responsible for directly commissioning screening and immunisation services. And our priorities are listed in the slide deck. They relate to ensuring that these services are of high quality and they meet national quality and performance standards. But we do also lead on transformation of these programs, so changes to the eligibility criteria, introduction of new immunizations, new screening tests, and so on. But increasingly, we want to focus on actually improving the population health outcomes. Can you hear me? Yeah, okay. The population health outcomes that these programs are trying to address. So one of the things that we will be focusing on over the next 18 months is actually eliminating cervical cancer through a combination of increasing cervical screening coverage and HPV immunization, because these are the golden or the silver bullets where we can actually eliminate cervical cancer as a public health problem in London. I'm not sure what's happening with this mic. I apologize for that. Sorry? Okay. So I won't go into too much detail in terms of the overviews of the program. Just to say, with bowel cancer screening, it's offered to men and women every 2 years, and it's a test kit that's sent to your home, and you take a small sample of poo and you put it into a test tube, and the NHS will test it for blood. And the bowel cancer screening program actually prevents cancers because we identify lesions or polyps in the bowel that, if they are left untreated, could actually cause cancer. But it also helps us to detect cancer early. and reduces your risk of dying from bowel cancer by 25%. So the bowel cancer screening program is highly effective, and it's important that we ensure that people participate. And in terms of uptake and coverage, it's an extremely good news story. The coverage in Merton has actually increased by 10% since 2019, and Merton is now above the acceptable standard of 60%. Merton still remains below the England average, but not too far behind. But Merton is above the London average for bowel cancer screening coverage. Cervical cancer screening, again, is a highly effective program whereby if you take part in the cervical cancer screening program, it actually reduces your chance of getting cancer and enables us to detect cancer early. And the program in itself has actually reduced deaths from cervical cancer by 70% since the 1980s. This is a highly effective program. And we offer screening in GP practices every 3 years to women aged between 25 and 49, and every 5 years to women aged between 50 and 64. But the issue with the cervical screening program across England, across London, and in Merton is that the participation rates are actually declining. So since about 2011, 2013, we've seen a sharp decline of about 11% in coverage across London. And this is particularly so in younger women aged below 50. In older women, 50 to 64, we have seen a decline of about 6%. So it's not of the same rate as we see in the slightly younger women. But the positive news for Merton is that between 2021 and 2022, the borough saw one of the largest increases in coverage in women aged between 25 and 49 in the country. London was the only region to see an increase in cervical screening coverage. And Merton definitely ranked amongst the boroughs with the highest increase in that younger age group. And this is largely due to the interventions that I have listed in the appendix. We ran a very effective social media campaign, engaging with social marketing campaign. And we did a lot of community engagement using our trusted voices, faith leaders, social influencers who went out into communities, promoting cervical cancer, speaking to women in safe spaces and speaking to them in their own languages. So we had doctors and nurses going to speak to Somali women, Bangladeshi women, and so forth. Now, there are a variety of factors that affect the participation in these screening programs. Now, with cervical cancer and both bowel cancer screening, people have a fear of actually being diagnosed with cancer, so they'd rather not know. But also, there's an issue with test acceptability. Cervical screening can be uncomfortable, as female colleagues would be aware. It can be quite uncomfortable. And with bowel cancer screening, people are not comfortable handling their poo. And these are the reasons why the participation in these programs is not as great as it could be. Now, if I focus specifically on cervical screening, because this is a screening test that's done in general practice, we do have some issues with access to general practice appointments, having to phone your GP in the morning to make an appointment. This sometimes is a barrier for women to access cervical screening, and the appointments on offer are not always available at the times that suit women, particularly if you've got care needs, if you're working, if you work outside of the borough, and so on. Now, the interesting thing about cervical screening in London is that we don't see an association of deprivation. So women in deprived boroughs are not less likely to participate in cervical screening. We don't see lower cervical screening rates in Black African, Black Caribbean women or Asian groups. There is no difference with white British groups. Where we do see a difference is in white other. So that's white, Irish, Polish, Romanian. And there's been quite a lot of work to understand what the reasons are for this. It's partly to do with lack of trust in the NHS, people from these communities going home to be screened, every year, and in their own country, they'll sometimes screen by a doctor. With both cervical and bowel cancer screening, there are certain groups that are less likely to participate in screening. So people with learning disabilities, people are homeless, people who are in detained estates, so people in prisons. So in terms of the work that we are doing to improve uptake and to reduce health inequalities in both programs, we have 6 main pillars in London. The first one relates to transformation. So we want to expand the bowel cancer screening program to offer it to people from age 50. With cervical screening, we are keen to introduce home testing, so self-testing for cervical screening, and we think this will make it more convenient for women to participate in the program. We want to make marketing, communication an integral part of the NHS England core offer. Because of the success of our campaigns, we know that we can be very effective in terms of reaching people from different languages using different channels, radios, radio adverts in different languages, paper, print in different languages, and also getting social influencers, trusted voices, faith leaders, and celebrities to endorse our programs. And we found that this has been highly effective in London. So I've listed in these slides some of the other work that we'll be doing to improve access and some of the research and innovation that we'll be doing across both programs. In terms of targeting underserved groups, we do offer both screening program to people with severe mental illness and forensic secure units across London. We offer bowel cancer screening in detained estates, so in prisons across London. We don't have any female prisons that are commissioned by NHS London, so we don't. So there isn't an issue of offering cervical screening in prisons in London because we don't have any female prisons. But we do commission a specialist cervical screening service for victims of sexual violence, which is called My Body Back, and we are currently working on developing pathways into cancer screening for people experiencing homelessness, and this is being led by our colleagues at North Central Cancer Alliance. Now, unfortunately, my colleagues from Southwest London Bowel Cancer Screening Centre and from RMP Cancer Alliance were not able to stay on the call this evening, but in the deck, you'll see examples of some of the fantastic work that they are doing in Merton to improve uptake and to improve the quality of care that we provide in the NHS. So I'm happy to take questions. Thank you.
Thank you very much. Anybody have any questions? Yeah. Tony.
Well, it's not really a question. I just want to say how impressive I think that work is. And there was a comment made earlier by the immunization group that they wanted to see this in a more holistic sort of way with the screening and vaccinations being included. I would have thought they could learn a heck of a lot from your community engagement programs and your marketing and advertising that you've been doing. So I just wanted to say I'm very impressed. Thank you.
Thank you very much.
Just a quick question from me. I noted that in the deck, which was really great, by the way, that there's under equalities, it has underserved groups, including non-binary, trans men with a cervix, people with experiencing homelessness and everything. And sort of, I wondered what specific, if there are any specific measures that you're putting in place that I've seen in other NHS trusts or other NHS campaigns to encourage those trans people to come forward and have their cervical screenings, given the level of sort of interest in it in the general media and the sort of barriers that they might face and the comfortables they might face in coming forward for these screenings. If there's anything specific that you're putting in place.
So in our cervical cancer screening campaign, which we ran last year, there was specific messaging targeting trans men of the cervix and non-binary and the non-binary community via their platforms, where we made clear the pathway to access screening. So if you are non-binary or trans and you haven't actually changed your sex to female via the NHS, you will still be invited. But there will be some trans people who will change their sex to male, which means that you will not be invited automatically. So there has been an associated piece over the past 3 to 5 years working with primary care to ensure that they invite themselves, general practice invites their trans non-binary patients who are not being automatically invited into the practice to be screened. And there's now very clear guidance to all aspects of the NHS to ensure that the pathway to screening is clear and that we can actually record the results, communicate the results, and that the experience and the pathway is equivalent for trans and non-binary individuals.
Yeah.
Thank you very much for that information you've given us. It's very interesting. I'm pleased to hear that the cervical cancer rates have improved for the screening. Looking at the colposcopy waiting times, I don't know if you can give me some bit more background information why those are so low. It does mention there about St Heliers focused capacity on high grade referrals. I know the wait time is 6 weeks and the other ones are 2. For any woman who's waiting for results and are waiting for that, it's incredibly, the anxiety levels for women. And the data that you're giving here for 22, 23, 54%, they're very low. Those levels, what's happening and how long will it take to catch up on that? Thank you.
So there is an issue with the colposcopy waiting times across London, and we differentiate or we risk categorize women who have abnormal cervical screening results into high risk and low risk. So high risk are those who have lesions at screening that are very probable to develop into cancer if they're not treated, which is why we try to see these women in 2 weeks. And the women with low grade disease are at lower risk, which is why we have a waiting time of 6 weeks. So the issue relates to workforce, colposcopy nursing in particular, but also in terms of administration. There just aren't enough staff to cope with the number of referrals. There was a significant increase in colposcopy referrals when we introduced HPV as the screening test, which we did in 2019. And this meant that we have seen this peak across the country of women coming into colposcopy, because HPV as a screening test is far more accurate than what we were doing before, where we just look at the cells but not actually test for HPV. And trusts across the country are grappling with how to actually recruit enough nurses and admin within colposcopy to cope with this. NHS England nationally is doing a big review of colposcopy services across the NHS, looking at various options. And I think one of the options we may need to consider is rationalizing colp units. So in London, we have about 26, I think, and most of them are not meeting the 6-week waiting standard. So it might be time to think of maybe if we have smaller, larger units, better staffed, we might be able to get women through the door more quickly. There may be an issue of access, but we just need to maybe consider that as an option.
Yes, thank you for saying that, actually, because we were wondering whether we could actually get a mobile unit in Mitcham, maybe in Wilson, of a cancer screening unit. You could always do cervical tests there and breast screening, another screening there, which will also help the community.
So with colposcopy, it's actually women who have already been screened found to have an abnormal result and now require secondary care. So it does need to be in a secondary care setting. And the issue with colposcopy is not so much of locations. We have enough locations, it's the staff. But in terms of finding additional venues to offer cervical screening, because as I mentioned at the top of my piece, we have within our gift all the tools we need to eliminate cervical cancer in London. We do need to offer screening in more venues. We need to make it easier for women to attend screening at a time that suits them. So if I want to go at 8:30 on a Wednesday morning, I should be able to do that at the Wilson. I don't have to go to my practice, or if I'm on my way to the gym. And I should be able to book via an app. I shouldn't have to phone my GP. And I think this is possibly some of the big thinking that we need to do at a place level, but also at a London level, that how can we increase our cervical screening coverage quite significantly to actually avoid cervical cancers. Because with screening and with vaccination, all cervical cancers are avoidable. We shouldn't be having any cervical cancers in girls, women who are below 30 who've been fully vaccinated. So really, we need to improve our HPV vaccination rates and improve our cervical screening coverage rates by improving access. And of course, dealing with the, some of the behavioral barriers, making the service more accessible to the inclusion groups and so forth.
Just a quick question. In terms of your engagements within under 30, how are those being done? Are you connecting with them? Are you sharing any information about this screening to them, or are they aware of when there is this certain age that's where they need to go to the GP to book this appointment?
So for all of our screening programs, you will receive an invitation letter from the NHS when you are due. So you yourself don't have to do anything. You will receive a letter. And in London, we're the only region to do this. We also send a text reminder to every woman who is invited for cervical screening. And if you don't attend, you receive a reminder letter, and we also send you a reminder text. As part of our campaign, our social marketing campaign, we did a lot of work on social media, where we reached over 2 million young women using a combination of Twitter, Facebook, and Instagram. And we were particularly successful in reaching young women under 35. I hope that answers your question.
Right, thank you. Anybody else? No? Thank you very much, and thank you for your patience in waiting so long. Thank you. Hopefully we will get an update for you soon of what's happening and where we're going. Okay, thank you. Right, we're on the work program. I think it's you, John.
Thank you, Chair. So the Health and Scrutiny topic workshop took place on the 14th of June. Stella Akitan, our scrutiny officer, was going to update, but she's not able to come tonight, so she's asked me to update on the agreed scrutiny topics for the next year. So the first thing, that all of the topics put forward for the coming year were agreed, except for two. The two that weren't agreed were vaping and substance misuse. The committee agreed that vaping was a serious issue, particularly affecting younger people, but it was on the agenda for the Health and Wellbeing Board, and the Scrutiny Committee felt that that would be the best place to look at that issue. The second topic that wasn't agreed was substance misuse. Again, the committee agreed that it was an important topic and that it should be deferred to next year and prioritized for the forthcoming year, with one of the first things to be looked at. You're only able to have 6 to 8 scrutiny topics, so they wanted to prioritize the ones that they felt were really important for this year. The first one that was agreed was again a request that James Blyth and his colleagues return from St Helier to update us on the status of the planned new build and capital repairs to the St Helier building. It was requested that that came back nearer the end of the year, 6 months after tonight. The second topic that was agreed was to have a real in-depth look at men's and women's health. For women, it was discussed to look at the menopause, gynecological health for women, and breast cancer, with a focus on prevention, younger people and how they're prepared for the menopause and gynecological health, and a focus for men on prostate cancer, heart health, and possibly one other topic such as bowel cancer, which was just discussed just now. Again, looking at prevention, treatment, and the rates of testing for that client group. The committee requested that our health colleagues came and updated us on the Wilson Wellbeing Hub and the Rowans and Collier's Wood Surgery, GP surgery in the east of our borough. And they wanted the report to specifically cover the timeline for delivering those services and what the clinical model will be for the new Wilson Wellbeing Hub, the Rowan surgery and Collier's Wood surgery, with a clear timeline. There was also a request from our young inspector around the Wilson Wellbeing Hub, around how the services links to CAMS, to children's mental health services, and what services will be available to young people. The next topic that was agreed was our adult social care's home care contract. We provide 8,500 hours of home care to approximately 1,500 people a year in Merton, 8,500 hours a week in Merton to about 1,500 people a year at a cost of between 10 and 12 million. We are going through a procurement exercise at the moment to implement a new model in October, and it was agreed that that model would be looked at probably in the new year to look at the outcomes for residents and look at how we've implemented that new home care contract, where we'll be paying the London Living Wage. We agreed another one for adult social care was a look at the carer strategy. We've got a high number of informal carers in Merton that provide a huge amount of unpaid care to their neighbours, friends, loved ones. We have a carer strategy which started in 2021 and goes all the way through to 2026. And there was a request that that was scrutinised, but also the carer strategy, we also looked at carer services, support services and carer services for older people and for people with learning disabilities. Another area that was looked at, the final area that was looked at, was how the work that the NHS do to keep people out of hospital when they do not need to go to hospital and when those services could be provided in the community. And that was a focus on primary care and the work that primary care do to keep people well in their own communities, secondary care, tertiary care, and a specific look at virtual wards, which is a governance policy around how you can get people out of hospital with a wraparound service, and of course keeping people in the community and out of hospitals. For the task and finish, the task group agreed on scrutiny was for a look at the care quality assurance preparedness. Adult social care is now it is part of a quality assurance regime, and we will be inspected by the Care Quality Commission. First time since 2009 that adult social care has been inspected, and there are 9 lines of inquiry that the Care Quality Commission will be looking at, and it was agreed that the the task group would look at one or two of the main key lines of inquiry. And it was agreed that Phil Howell, AD in Adult Social Care, would work on that with the chair, co-chair and the scrutiny officer on how best to move forward with that. The final thing that the panel asked was that they would like to undertake a number of visits to St Helier Hospital to look at the state of disrepair. The panel were clear that they did not want a whitewashed visit to be looking at the reasons why the NHS feel that a new hospital is needed. They actually wanted to go and see the state of disrepair and have an understanding of how that disrepair will be challenged. Those were the task groups for the scrutiny group topics for the next coming year. Thank you, Chair.
Done. Are we okay with that? All right, thank you very much. So safe journey home, everybody.